So officially, I welcome everyone to today's webinar, and this is officially the second episode of Frontline Echoes. And this particular episode is very important because we are actually doing it to commemorate the World Malaria Day that was celebrated on the 25th of April. That was 2 days back. And as we all know, malaria is a thing, an epidemic, especially in the global south, that is most of the low and middle income countries, with Cameroon being one of the high burden countries, as we saw our presenter during the last episode. So today we're actually having the experts who are actually on the field, who are working hand in hand with this vaccine rollout in Cameroon, who are going to be addressing some of our questions. So I implore all of us to share the link to our friends that are here to join, and also to pay very keen attention while the presenters will be presenting. If you have any questions, please do write them down, and I'm sure there's going to be a time for the Q&A session. If you cannot wait, then you can just drop your questions in the chat section as well. If you have any contributions, please, the chat is always open. Please feel free to drop your suggestions in the chat box. So I don't know if Dr. Itoe is present because he's supposed to begin the session. Dr. Itoe, I don't know if you're present, so I can allow you to be able to share your screen.
Yes, I am. I'm present. Thank you.
Okay, let me give you the permission to share your screen so that we can begin. Just a second. Okay, you now have the permission to share your screen, please.
Okay, thank you very much.
So while Dr. Itoe is preparing his slides, it's an honor for me. I always feel like when I introduce people, maybe I don't do so much justice to their profiles because we have very heavy profiles that are present here today. But just a brief about Dr. Itoe. He is actually the Southwest Regional Coordinator for the National Malaria Control Program in Cameroon. He's also a public health expert and a frontline epidemiologist. So that's to tell you that you're going to be actually hearing from the horse's mouth himself. I follow a lot of his works on malaria. He's been very busy this past week, from so many radio talks to TV sessions to malaria walks. So this is the person that we have presenting valuable information to us. So I think we are very, very privileged to be getting first-hand information about the vaccine. So over to you, Dr. Itoe.
Thank you very much. Good evening, everyone, and thanks for joining us in today's session. I would just turn my video for 1 second and turn it off to maximize. It's not even important at the end. I can turn on the video, so I'll just go straight to the presentation. So I'm Dr. Itoe. I'm the coordinator for the national program, the regional technical group for the fight against malaria Southwest. Please, can you hear me?
Yes, we can hear you loud and clear. Yes, I can hear you loud and clear.
Thank you. So we will just try to paint, before talking about the vaccine, I will try to paint the problem. Is malaria really a problem in Cameroon? And so we'll try to paint the picture of the problem and then see the few challenges that we're facing. And then I will introduce for Dr. Pamela to continue about the vaccine. Is malaria a problem in Cameroon, particularly in the Southwest region? In 2022, we had a malaria indicator survey where we basically went to the community, I'm talking about Cameroon, to see what the prevalence and what are some aspects of malaria in the community. And this survey showed that across the national territory, about 26% of all children less than 5 who were tested positive for malaria, while in the Southwest region in particular, which is affected also by the conflict, affected by the crisis, just a few months after the disease distribution campaign, we're shocked that despite the progress made in the health facilities, to reduce the burden. The prevalence of malaria was still almost 30%. That's almost 1 out of every 3 children who were tested positive for malaria. Just to see that, you can see some other aspects there that we equally had a little bit of not very optimal usage of some preventive measures, like both availability and usage of mosquito nets, which was just slightly higher than 50%, both national and regional territory. And with this, now coming to the health facilities, we realize that there is decrease in the number of the proportion of malaria cases in the health facilities in the Southwest region, even across the national territory. But still, generally, malaria accounts for about 1 out of every 5 consultations in Southwest region, and is higher in the national figures. We can't accept this. When it comes to death, we know that children less than 5 are the most affected. About 1 out of every 3 consultations in this age group is because of malaria, and then they account for almost 60% to 70% of all malaria deaths recorded in the health facilities. What is the ministry doing? We know all we are doing multi-sectoral engagement. We are pushing. We have vector control measures like sharing of mosquito nets every 3 years during mass campaigns. Chemo prevention. Chemo prevention, which is vector control, sharing of mosquito nets during mass campaigns is one. We also share mosquito nets routinely during antenatal consultations, and also infant welfare clinics. The challenge that we have here is that pregnant women come late. As a result, they don't benefit early enough from these packages, and children less than 5 sometimes come and they boycott the vaccination sessions, and this affects or makes them to miss receiving their preventive treatment and also their mosquito nets. Preventive treatment is also given to pregnant women on a monthly basis once they are eligible during their ANC. And in the north and final regions of Cameroon, where we have seasonal variation of malaria, they have seasonal malaria chemo prophylaxis ongoing there to target this problem. What I can say in case management is that I'm just keeping the vaccine because we'll talk about it later. But one good news is that we have now the malaria vaccine, which is an innovation. We have been praying for this vaccine for a very long time. Thank God it finally came. For case management, we just want to push that we should diagnose malaria early enough and treat it appropriately for it not to change to severe malaria, which is a form that leads or transmits or changes to death. And also we have the free treatment policy where children less than 5 are supposed to be treated free of charge for malaria, particularly in public health facilities in the context of universal health coverage. We have to push, we have research strategies and there's coordination of the national response. The challenges are there. We have insufficient funding. Resources will never be enough. From my almost 3 to 4 years in the NMCP, I know that we'll never have enough resources to fight malaria, particularly the fundings. So we need to look for means to mobilize local funding. The community is, at the moment, the engagement could be more to ensure that they are engaged for us to adhere to the current policies and fight the conspiracy theories which can make us not get optimal results, and also ensure that the challenges on the ground are met. In the Southwest region in particular, we have this insecurity, which I'm not going to emphasize on how it affects healthcare in general and malaria in particular. What can we do? You see the team, I think the moderator already gave small highlights on the team. Health, advancing gender equality, health equity and human rights, and the slogan accelerating the fight against malaria. We know that the African region is disproportionately affected. Cameroon is amongst the top 10 most affected countries of malaria in the world. And these high burden countries account for almost 90% of all the malaria burden. Africa being, first of all, poor, and then malaria coming again to disturb, you see, just causes the vicious cycle of inequality and lack of equity. So we really think that there is need for us to invest more, both financially, human resource, and our time in the fight against malaria. There is need for us to ensure that we push and capacitate the community for community engagement by ensuring that we involve them, we inform them, we collaborate with them, and bring them right in decision-making processes and conception of projects. So what I'm saying is, if somebody gets sick, we need to ensure that we do research to get data and manage the cases very well, but we need to prevent and prevent and prevent, because prevention, they say, is better than cure. And while doing all this, there is need for us to prioritize the vulnerable. I'm talking about the vaccine. These children are really vulnerable. That's why they're the ones who are benefiting from the vaccine. And also prioritize other age groups like pregnant women and IDPs that we have in our setting. But there is urgent need for action, because time to act is now. Who is involved? Everybody is involved. The schools are involved, the mayors are involved. An investment in malaria has a positive return on investment. And if we don't act now, based on the biological changes that we are having, the mosquitoes are changing, there is resistance that is upcoming, there is climate change, and just many factors. Either we spend now or spend about 10 folds or 100 folds in the nearest future. So everybody is involved. The secondary, basic and secondary education need to come on board, because malaria is amongst the top causes of absenteeism from school. And if these children are missing school and they're the future of tomorrow, it means our future is a threat. Healthcare workers need to be more involved also. We realize that healthcare workers for now, some of them focus, particularly those who are not in public, they focus more on diagnosing and treating malaria, but we need them to be advocates to push for community engagements for health promotion and prevention services. Women empowerment and all the other stakeholders have to come on board. But the community, which is most affected, need to take the lead in the fight against malaria. For them to do so, we, the healthcare workers, need to capacitate, advocate, and engage them to ensure that they have the power to do community mobilization. This is just to say that we need to ensure that all stakeholders, we don't just tell them, we inform them, we consult them, we involve them, we collaborate with them, but lastly, we look for means to empower them so that they can be able to take the lead as far as malaria fight is concerned. We really need to be, as most of us have watched this movie, we need to be gladiators in the fight against malaria. We need to be resilient. We can't give up. Other countries have done it. We can do it. So all of us, beginning from the Ministry of Health, right down to the community and other stakeholders, need to take that personal action. But when? Take it now. The NMCP, the malaria vaccine is there. We've rolled it out in about 42 health districts, 3 in the Southwest region, as you see. That's an innovation. We are reinforcing CDI activities to ensure that the community takes the lead. We supply medications both free for children and subsidized across the national territory. And in the context of universal health coverage, all these packages were going to increase access to care while continuing ongoing research to ensure that we have enough data to do subnational tailoring and take care of our own decisions. And also, we are advocating for both international and local funding. That everyone is
we lost you, Dr. Itoe. I think we lost you somewhere. Can you hear me?
Yes, we can hear you.
Okay, I think we temporarily lost Dr. Itoe. So welcome to everyone that's joining. We are talking about malaria. We are talking about the malaria vaccine rollout in Cameroon. As we know, Cameroon is one of the first countries in the world to officially roll out the malaria vaccine. So yeah, I think we lost Dr. Itoe. So he has been a very active force in the campaign against malaria in Cameroon, especially in the Southwest region of Cameroon. And I think while we are waiting, we'll move on to Dr. Pamela. And I'll be sharing Dr. Pamela's slides. Dr. Pamela is the coordinator for the expanded program on immunization in the Southwest region of Cameroon. So this is, I'm talking about somebody who is very active on the field. I mean, very active, those who are actually giving out this vaccine. So we are all very privileged to be getting first-hand information on what's going on in Cameroon right now. I know we have also people from different countries that are also waiting to roll out this vaccine. So it's a privilege that we all have. We are hearing firsthand from Dr. Pamela, who has been active in the API zone in Southwest Region. So over to you, Dr. Pamela. Just tell me when you want me to move forward and when you want me to stop, and I will be glad to assist you.
Hello, Adanze. Hello, everyone. I think it's an honor to be here talking about malaria vaccination. I think that Cameroon has been put on the international, it has been put on the map globally to be the first country to officially roll out the malaria vaccine in routine immunization. And I'm going to be bringing first-hand experience, but also my knowledge on this malaria vaccine. Malaria is a threat. It's a global health threat, but also mostly a threat in Africa because we account for most of the burden, most of the malaria burden. And just like Dr. Itoe rightly said, 1 out of 3 children, 1 out of 3 people who go to the hospital actually consult for malaria. So the reason, or is it important to have this vaccine? Very important. It's very crucial because by having a vaccine, it's going to help us to prevent mortality, morbidity associated with malaria. And of course, we know that it mostly affects children less than 5 years of age. So permit me, I'm going to close my video for now, and you only hear my voice while I do my presentation.
Do I move to the next slide?
No, I'm still on the first slide. So when talking about the malaria vaccine, we're going to be focusing on this very interesting picture. For those who work in the immunization program, we know that with vaccines, we usually have a single vial, but with this particular malaria vaccine, the first ever malaria vaccine that has been rolled out, that has met the phase 3 trial and has been rolled out, we have 2 vials. We'll move to the second slide.
Sorry. Okay.
Okay, next slide, please. So we're going to be talking about the RTS S vaccine, with the brand name Mosquirix. Now, what is this vaccine? This is a vaccine that was created by GlaxoSmithKline since 1987, and it's taken a long time for this vaccine to be accepted, for this vaccine to be pre-qualified, and for this vaccine to be introduced in routine immunization. So RTS and S, why do we have this particular name? The first thing we need to know is that the malaria vaccine is similar to any other vaccine in the routine immunization system. What do I mean by that? A vaccine is composed of an antigen. It's composed, and the antigen is supposed to produce an immune response. So now when we're talking about the malaria vaccine, we're talking about a vaccine that has as antigen the second sporozoite protein for the sporozoite stage. And we know that the sporozoite stage is the infectious stage of the Plasmodium falciparum. By using this particular second sporozoite protein as an antigen, there is a possibility of creating an immune response that is able to produce antibodies that protect against malaria and Plasmodium falciparum. Remember, I'm talking here about Plasmodium falciparum. Why? Because this vaccine mostly targets Plasmodium falciparum, which is the deadly form of the malaria parasite. Now, the RTS and S are just hepatitis B surface antigens that have also been combined to produce this vaccine. And the vaccine is administered alongside an adjuvant, AS01E. So we have the name RTS stroke AS01E. Next slide, please. Okay, so this is the presentation of this vaccine. And on the left side, the vial with the red ring is actually the powder for suspension, which is the antigen. And on the right side, the adjuvant I mentioned, AS01E, is the adjuvant, which when mixed together is going to give us our malaria vaccine. composed of 2 doses, which is supposed to be administered within a period of 6 hours. So this is very similar to all the other vaccines in the EPI program, which are administered in routine, stored at a temperature of +2 to +8 degrees. The next slide, please. So I earlier mentioned that the RTS S malaria vaccine is not different from all other vaccines. I say so because it went through the clinical trial processes like all other vaccines. So we have the preclinical stage where studies are carried out in the laboratory, and there is testing in the laboratory. We have the phase 1, phase 2, phase 3 trials, which are carried out to determine the side effects, the safety, the dosage of this particular treatment. And of course, we have the phase 4 stage, which is the pharmacovigilance stage. After introduction into the population, we have continuity where monitoring of the adverse events of the vaccine continues to take place. So the malaria vaccine went through all these different stages, and it even went through more. We're going to be talking about that later on when we look at the malaria vaccine implementation phase that took place in 3 characteristic countries in Africa. Slide. So we spoke about, we said the malaria vaccine went through a preclinical phase, but also clinical trials. And we have 5 randomized controlled trials that were carried out in 7 sub-Saharan African countries. So in Africa, we, the African population, were part of the development of this vaccine. And following all of this, it was determined that the malaria vaccine was safe. It wasn't only safe, but it was effective in reducing a clinical manifestation of the disease, particularly severe symptoms severe disease that occurs in children, and also effective in reducing morbidity and mortality. Following this clinical trial stage, to further ascertain the safety and also the ability for this vaccine to be rolled out in routine immunization, a pilot implementation phase, which we call MVP, was carried out in Ghana, Kenya, and Malawi since 2019, and it finally ended in 2023 with over 2 million children vaccinated in this country. So it was characteristic representation of how it would take place in any country in routine immunization, and it was definitely successful. Slide. So in this next slide, we're able to see the efficacy results that were obtained from the malaria vaccine clinical trials. And what we see is that children aged 6 to 12 weeks, we had children aged 6 to 12 weeks in the group. We had children aged 5 to 17 months. We realized that the children who received 4-dose regimens and received vaccines up to from 5 to 17 months of age, actually, there was a higher efficacy going up to 36% than those who received the 3-dose regimen. So this led to the recommendation that the malaria vaccine should be administered as a 4-dose regimen to get maximum protection for these children who are very vulnerable. Slide. Okay. The immune response for the malaria vaccine, the RTS S, is actually, as seen in the previous slide, we see that when you administer 3 doses, you have a very sharp rise in antibodies, which decreases very, very sharply as well. This is the reason why it's important to administer a booster dose around the second year of life, so around 24 months, the second dose, which is responsible for boosting the antibodies produced against malaria. And this again goes to explain why it's important to have a 4-dose regimen instead of a 3-dose regimen, so that the child who is vaccinated would receive the 3 doses in the first year of life, and the second year of life, where the child is still vulnerable, they'll be able to receive an additional booster dose that will protect them. Slide. So this vaccine has a very good safety profile, because when manufacturing a vaccine, it's not only about the vaccine being effective, it's not only about the vaccine having impact, it's also important to have a vaccine that has a good safety profile. So far, the most frequently reported adverse events during the MVP phase were fever, irritability, and pain at the site of injection, which is actually very good news. And for the most severe adverse events, it was also possible to see febrile convulsions within a 7-day period of vaccination, which was actually very low. Only 0.1% of the children who received the malaria vaccine observed these adverse events. Slide. Okay. I earlier mentioned that the malaria vaccine really resembles all the other vaccines that are present in the immunization program. It has a very good shelf life of 3 years. It can be stored at the temperature of +2 degrees to +8, which is the temperature that we store our vaccines in the routine immunization in the EPI program. This vaccine too can be kept in its original packaging to prevent it from being destroyed by light. All of this is very common with these characteristics are common with the other vaccines. So the vaccinators, or even at the health facility, people have not really had a lot of challenges with using and storing this vaccine. Slide. We also need to talk about the R21 matrix, because it is the second malaria vaccine to be pre-qualified and also to be recommended by WHO. The RTS S vaccine was the first to be recommended. This one too has been recommended and also pre-qualified, and Cameroon, as well as other African countries, would be receiving this second malaria vaccine. Why is this important? It is important because the doses that were received for the malaria RTS S vaccine were actually limited. So the addition of this vaccine will be able to cover up gaps that have been identified in supply of the RTS S vaccine. Slide. Now, I want to say that the malaria vaccine actually had a very long process in the country. Because unlike what social media wants us to believe and what many people think, that the Cameroon government just received this vaccine and we just put into use, it actually had a very long process through which there was government guidance. We have the National Immunization Technical Advisory Group, which is a scientific group that is responsible for providing scientific evidence for immunization policies. And many scientists, great scientists like Professor Rose Leke are part of this NITAC, and they are responsible for a lot of policies that are made in the EPI program. So they were responsible for providing their opinion on the introduction of this vaccine in the country. We also had the interagency committee decision to actually validate the decision or the opinion of the NITAC. We also have the NITAC recommendation that was revisited, because at the beginning, the NITAC preferred that the malaria vaccine will be administered in the form of a campaign during the period of high seasonal transmission. But later, this recommendation was revisited, and it was decided that the malaria vaccine will be administered as in routine immunization, and this was done in January 2023. Thereafter, we had stratification and selection of the districts to say that not all the districts in Cameroon carry out malaria vaccination, and we'll be seeing why this is that. Then we had support from our developmental partners such as Gavi, and we had receipt of the malaria vaccine in the country, and then launch of vaccination, which took place this year in January, in the month of January. Slide. Can you go to the next slide, please? Thank you. So we spoke about the MVP phase, Ghana, Kenya, and Malawi. And remember, we mentioned that this particular program was very important as it informed us, it informed Cameroon and many other countries that were planning to roll out this vaccine on the safety of the malaria vaccine. We also see that the vaccine was effective in reducing mortality in these countries by at least 35%, which was actually excellent news. Unlike what people believe that vaccines are free, and because something is free, it means it's dangerous. The vaccines are free, but someone is paying for them. The cost per dose of the malaria vaccine is $9.7, which is roughly about 5,000 francs per dose administered in a child, which is actually very, very expensive, or significantly expensive. Imagine buying a drug for your child and maybe just one dose of that drug cost 5,000 francs. Can we go to the next slide?
This is the next slide.
The next one, please.
Okay.
Okay. So how was the malaria vaccine or how were the zones for the malaria vaccine? Can we go to the next one, please? Thank you very much. How were the zones for introduction of malaria vaccine selected? The first thing, what we need to know is that in the country, we have areas of high transmission, areas of moderate transmission, and areas of low transmission. So the areas of high and moderate transmission were prioritized for the malaria vaccine. Why? Because in these areas, they have more bites, and in these areas, there is a higher morbidity and mortality rate due to malaria. In the Southwest region, for example, we have the district of Limbe, Tiko, and Manfe that were prioritized as districts that would start the malaria vaccination rollout. This means that other districts would also be added subsequently to receive this malaria vaccine. But for this first phase, these are the districts that were prioritized. And like I earlier mentioned, when the R21 matrix vaccine comes, it will give opportunity for other districts as well to benefit from this vaccine rollout. Slide. So here we have a total of 63,649 children identified in these 3 health districts for the Southwest region that will be receiving the malaria vaccine, or were planned for the vaccine introduction. Next slide. Like I earlier mentioned, it was all based on the morbidity and the mortality of the malaria parasite. Slide. Another criteria that was used was the dropout from Penta 1 to Penta 3. Why? This is very important because it would give us an idea of the districts that would be able to continue vaccinating their children from the first dose to the 3rd dose and even to the 4th dose of the malaria vaccine. Remember, we mentioned that the malaria vaccine is administered in the 1st year of life, but also in the 2nd year of life. And it will not be good to have a dropout. If we have a high dropout rate, it means the children are not completely or well protected, and therefore it's almost like a useless dose. So it was important to have this classification, which guided us to select the 3 districts that were prioritized for the activity. Slide. Here. We said overall in the country, we have 41 districts that were identified in all the 10 regions. Slide. So now we look at the malaria vaccine schedule, and we take note that the malaria vaccine is administered in 4 doses, 3 doses administered at the first year of life, at 6 months, at 7 months, at 9 months, and then we have the last dose that is administered at 24 months. This is the first of its kind, as there is no other vaccine that it has been administered in the vaccination program in Cameroon in the second year of life. So it's also an opportunity to catch up children who have missed 1 or more doses. It's also going to, we also, apart from the malaria vaccine, we have other interventions that are administered around this period. Or we have, for example, IPTI, that is also one of the interventions against malaria, which is administered at 10 weeks, at 14 weeks, administered with the malaria vaccine at 6 months, and then another dose administered at 9 months, and the last at 15 months. So we see that the IPTI and the malaria vaccine will be administered together at 6 months. Next slide, please. So there are so many lessons that we learned from the introduction of the malaria vaccine, which I cited a few, or best practices that were carried out. The first thing is that before the introduction of the vaccine, there was a readiness assessment tool that was used to follow up preparedness at all levels. So this is at the district level, at the regional level, at the central level, to see at what level is Cameroon prepared. Do we have the required cold chain equipment? Do we have a plan to train the vaccinators who will be administering this vaccine? Do we have a deployment plan? All of this was carried out or was followed up in the readiness assessment tool. We also use routine immunization tools such as tally sheets, vaccination registers, and in addition to that, we used the IAZO platform, which was used as an additional tool in reporting malaria vaccination data. Although it wasn't very easy with using the IAZO tool, the other tools like the registers and the tally sheets are tools that are very common to the vaccinators already. We had intersectoral advocacy meetings at the regional level. We had engagement meetings also at the district level, which gave an opportunity to bring all key stakeholders to inform them about the introduction of this vaccine. We have strong partnerships. For example, Gavi funded most of the trainings, and we had a technical supervisors, technical support from WHO and UNICEF throughout the entire process. Also, our AFI monitoring system is very active. We carry out active and passive AFI monitoring, which gave us an opportunity to identify adverse events that were notified during the introduction of this particular activity. Slide. Now we're going to be looking at the performance of the malaria vaccine introduction. Since January, we've been able to administer a total of 2,081 doses in the 3 health districts, Manfe, Limbe, and Tiko. So for Limbe, we have a cumulative coverage for VAP1 of 44%, for Tiko 31%, and Manfe that comes last at 26%. However, when we look at the coverage for the second dose of VAP, we see that Limbe has 8%, followed by Tiko at 3% and Manfe at 2%. So this is actually one of the major challenges we have with this vaccine, that there is a high dropout rate from the first to the second dose. And the strategies we're putting in place now is to ensure that all the data for the malaria vaccine introduction is captured in the different reporting platforms. And we're looking at reducing vaccine hesitancy through intensified community communication in the community and community engagement. And we are also working on addressing rumors through digital sensitization and through focus group discussions and community sensitization. because this too was very predominant during the introduction of this campaign and contributed to a lot of vaccine dropouts, but also to a lot of vaccine hesitancy. Next slide, please. So we have some pictures here that were taken during the malaria vaccine introduction. We did radio sensitization. We supervised the first day of the vaccine rollout in the Limbe Health District, and even the health talks that took place in Tiko Health District. Slide. So here we are on the left, at the governor's office where we had our stakeholder advocacy meeting, and on the right where we had training with the various district teams for the malaria vaccine rollout. Thank you very much, and I'm going to be available for any questions on this important topic.
Thank you so much. I can't even begin to explain. Like, I just felt like I went through another school, like a very elaborate school, and I just want us to share clap emojis in the chat section, because this is really premium, amazing information that Dr. Pamela has brought to us. So please just share thumbs up, clap emojis, or whichever one that befits a celebration in the chat section. Thank you so much, Dr. Pamela. And of course, there are so many questions in the chat section. My co-host Cynthia has been very active in the chat, and she has been sending me some questions that I would like to address. I would like to share with you for the sake of time. So for the very first question, we have Lizzie, and she says, do we have enough vaccines or systems in place to ensure the supply meets the demand? So I don't know, either Dr. Itoe or Dr. Pamela, any of you can just shuffle to answer the question.
Okay, thank you very much. That's actually a very, very interesting question. Like I mentioned, before the malaria introduction, we had an assessment tool, a preparedness tool, which helped us to monitor how prepared we were for this campaign. So as concerns coaching equipment, we do not have any problem with that. We have all the coaching available in the facilities. For those who do not have facilities who do not have coaching equipment, they conduct vaccination as outreach. So they take vaccines from the areas with functional coaching, and they go out to vaccinate these children. So we do not have any problem as concerns coaching. As concerns the number of doses, we do not have any issue. It's true that the doses are in short supply. That's the reason why only 3 health districts were prioritized, because the goal was that all the children eligible in these districts should be vaccinated. However, from the performance that you saw on the screen, we will see that only about roughly 40% of these children have been vaccinated. So it means that we have enough doses available at the health facility and even at the region that will be able to vaccinate all these children right up to their 3rd and 4th doses.
Okay,
Hope
thank
this
you so
answers your
much.
question.
I think Lizzie will either leave a comment in the chat. I just have a quick question. So let's say, for example, a baby or a parent brings their child to be vaccinated, and in that particular health facility, because I heard you talk about the fact that let's say in the future, Cameroon will also be rolling out both the RTS S and the R21 matrix vaccine. So assuming, let's say, a baby begins to get the 1st and 2nd dose of the RTS S, and let's say due to unforeseen circumstances in that particular district, or maybe they get to migrate, due to some of the challenges that the region is facing, is it possible for that child to continue the 3rd and 4th dose with the other vaccine, that's the R21 matrix? Is it possible, or they must have just 4 doses of a particular vaccine?
I think that's a very important question. But again, for now, remember I mentioned the role of the NITAG, and I mentioned the role of the interagency committee. So in Cameroon, there are many policies concerning vaccination that are decided at the higher level. Right now, because we have not received the R21 matrix, I cannot answer that question. Okay. And vaccination policies differ from one country to another. So what might apply in Nigeria might not necessarily apply in Cameroon. So since we do not have the R21 matrix vaccine in the country, and the doses for RTS S are available for all the children who are eligible, for now they should continue with the doses of RTS. So
Okay.
if they miss the dose because of vaccine stock out, you can always reprogram for another day. Remember, even if the vaccine, an appointment is pushed forward, it's not a major issue, as a vaccine dose, even if it's not given at the right period, it's still an important dose for the child to receive.
All right, thank you so much. There are so many questions, so you please bear with me. We are going to try to answer everybody's question, because that's the reason why sessions like this are being held, to be able to clarify us, so that we don't go around with those myths, we go around with facts that we can be able to share. Now, I have a personal question. You've been on the field, you're working in the API domain. What are the reactions of some of these parents towards the vaccine? Because I think it's been honest for us to be able to get firsthand information. I'm really curious about the reactions of parents that come. Are some of the parents, are they passive? Are they excited about the vaccine? What are the realities on ground with respect to the malaria vaccine in Cameroon? I think most of us here will be interested in knowing that, as well as some of the partners in different countries, to know what exactly are these reactions. Are the parents happy? What are some of the encounters you've had while on the field as an API expert?
Okay. I always say this is the age of vaccine hesitancy due to infodemic. So when you go down on the field, you have a lot of parents who believe in vaccination. They trust vaccination. But on the other hand, we have a lot of parents who are also very hesitant.
Mm-hmm.
And when we meet hesitant parents, it's always an opportunity to talk with them, exchange with them, understand their worries. The first thing is to understand their worries, because trust me, their worries are always legitimate.
Yeah.
The parent is worried for their child. They are worried because they have this message circulating on social media, especially lately. Before the introduction of the malaria vaccine, we had a lot of messages roaming around of the vaccine being this, the vaccine being that. So we meet a lot of that. But as experts in the immunization field, it's a continuous process.
Mm-hmm.
You try to understand their worries. You try to understand their background. We try to debunk these doubts, these rumors. We give them the right information. And we also tell them the impact of vaccination. Because trust me, vaccination is an intervention where the impact is so clear. Imagine that before you would have a family of maybe 7 children and 2 will survive. But now we have a family of 7 children and all of them are surviving. This is the major role vaccination has played by prolonging life, by ensuring that children are able to live strong and healthy lives. So we remind them of all of this. We remind them that it's true that a vaccine, there is a possibility of having a severe side effect, but these side effects that are severe are actually extremely, very, very rare.
Mm-hmm.
So there is a possibility. We will not deny that fact. There is a possibility, but it's actually extremely, very rare. Our surveillance system is active, and we are in the business of ensuring that all of the AFI are reported and managed.
I like the fact that you said we're in the business. I like the fact. I think Dr. Itoe has something to add, because his hand is up. It's very important that we get every clarification that we can get in sessions like this. So Dr. Itoe, over to you.
Yes, thank you. No, just to share an experience to say that even those that, particularly in the health facilities, those that come initially and they're hesitant, with time they themselves, because neighbors communicate, people talk in the community, they realize that the people who took the vaccine, their neighbors who took the vaccine, their children are doing well. So it changed their minds. I have this experience to share. A mother from Tiko, a grandmother from Tiko, who was there when we were in Motengene, CMA, who was there when we were giving the first dose. Her child had not reached the age of 11. So she came the next month, and her daughter, and give her strict instructions not to give the child the vaccine. So she didn't give the child the vaccine. But on coming and seeing that everybody is taking the vaccine and going back to the house and seeing that all the children who took the vaccine are doing well, she opted to bring her child back for the vaccine. You cannot imagine that she volunteered to pay her transport and join us in a radio station in CRTV to share her experience here in Boya. So just to share that experience. Thank you.
Thank you so much. That's the power of positive testimonials from vaccines. So to put some speed, the next question is from Manzo, and she's asking, what are the health promotion activities put in place besides education to promote the vaccine?
Okay, that's a very, very interesting question.
Mm-hmm.
So for now, actually, we're really focusing on education because when a vaccine is introduced, mind you, you realize that a lot of people do not have adequate information on this vaccine.
Mm-hmm.
We experienced the same situation with the COVID-19 vaccine. So based on this, based on our experience, we do a lot of communication, educating the population through health talks. And even as at now, our communication has focused on the districts that are implementing this vaccine. So we've really not gone further than those 3 districts in the region, which is a limitation. We need to be able to get everyone in the Southwest region informed about the benefit of this. We've been using radio platforms, but radio platforms are not as effective as community, community door-to-door or social group. Yes, so that is what we are looking at doing. Thank you.
Thank you so much. I like the fact that you accept that it's a limitation, because the aim, at the end of the day, the aim is for everybody, every child, especially in Cameroon right now, to get vaccinated. So it's important to also prepare their minds mentally before it actually reaches their domain. So we're pushing a little bit further because there are so many questions coming in. The third question is from Michelle, and she's asking Dr. Pamela, please, what is the composition of each vial?
That's this should be a scientist.
I think so. I think so. I think so.
Okay, so like I mentioned, this vaccine is not different from many other vaccines, which means that it has an antigen and it has an adjuvant. It has excipients. So here we have the circumsporozoid protein, which is a major surface antigen of the sporozoid stage, which is fused with a hepatitis B surface antigen and combined with another hepatitis B surface antigen. And we also, for the adjuvant, we also have an ASO1E. I don't know what this is. I'm not working in the laboratory, but it is Quillagia saponaria molina fraction and 3-O-deacyl monophosphoryl A. So this is the constituent of the adjuvant. And then we have the antigen, which I mentioned, which are the proteins.
Okay, thank you so much. Just to make an announcement, I think if you're interested in the slides of Dr. Pamela, please drop your email. I think most of the questions that are asking can be answered by her slides. So you can drop your email and then she will be able to share these slides with you. So the fourth question is from Lizzie again, and she's asking, Lizzie is very, very active in the fight against malaria, especially in Eastern Africa. So I think she's benefiting a lot from the webinar. She's asking, now that we have seen that mosquitoes are also changing due to climate change and becoming climate resistant, how effective is this vaccine?
That's actually a very interesting question as well, but I would say that science also evolves. We need to understand the efficacy of this vaccine in our real-life context in Cameroon before addressing maybe any failures of this vaccine. And as at now, we know that this vaccine is able to prevent the pre-erythrocytic stage, which is just one phase of maybe one phase of a vaccine against malaria. So we have the pre-erythrocytic stage, we have maybe vaccines that fight against malaria transmission, we have vaccines that fight against the erythrocytic stage and all of that. But for now, we start with this vaccine, and then with time, we'll be able to work on other vaccines that fight maybe against more resistant strains of Plasmodium falciparum. So this phase of implementation is going to inform other studies that are going to be carried out to ameliorate the vaccine.
Okay, thank you so much. You have so many questions on your plate, ma'am. So Cynthia is asking, why can't we just have a malaria-free continent or nation as others have it? Why must it be a vaccine? And what plans does the healthcare system have in place to counter religious views of so many that think that the vaccine is a form of attack on Africa? This is very important. Because you know, Africa, most of African religion, most of Africans have very strong foundations in their religious beliefs and their religious leaders. So I think it's a very key question.
So what I want to say first is that vaccination is one of the most effective health interventions. Why? Because vaccination reduces the burden on the economy, on the health system. And in a public health system, you will be looking at the most effective strategy that's going to limit mobility, that's going to limit vaccination. And vaccination is that particular strategy. That is the importance of having vaccination. Now, when you're talking about malaria, we are in a malaria endemic country. But just like, I don't know, remember which country, Dr. Itoe, I think it's also possible to be able to have a malaria-free country. Vaccination comes as an additional intervention to further curb the burden of malaria in Africa. It's not a standalone intervention. So we also have, in addition to IPT, in addition to use of mosquito nets, we now have the malaria vaccine. So which means that if IPT is limiting, your mosquito nets will help you. If your mosquito nets are limiting, the malaria vaccine is going to help you. In studies that were carried out, we realized that the vaccine, the efficacy of the vaccine was even raised by having other additional interventions given to get administered together, by having IPTI, by having the use of mosquito nets. We had an efficacy that went right up to 75%. So this is actually very important to know that it's not a standalone intervention, but it's one that takes place with all other interventions. Dr. Itoe might have something to add on this.
I see his hand up, please.
I just wish you said that personally. This is personal. I like vaccines because once you take it, it doesn't depend on your will or your engagement again for its effectivity. Mosquito nets, for example, are effective, but for them to be effective, you need to ensure that you make active efforts for you and your family to sleep under every night. But with the vaccine, once you take it, you don't have personal efforts again to put on a daily basis to ensure it's effective. That's why I like the vaccine. And this vaccine is effective also when, like Dr. Pamela, when you use all the combined package. I think that we can prevent almost 7 out of every 10 severe malaria cases if the whole package, including the other preventive measures, is well used. Thank you.
Thank you so much. We're just mashing on with fire to try to catch up with time. So Jude Anya is asking the follow-up question. What if parents do not give their consent for their children to be vaccinated upon? Should it be forced on them? And are there consequences like refusing them some services due to their refusals? What measures are in place to tackle such challenges?
Okay, so in Cameroon, there is no law that forces vaccination on anyone. Vaccination is strictly voluntary. And that's the reason why we continue sensitizing the population. It has to be free will. Remember, this is a personal decision. It's a decision to protect your child. It's a decision to ensure your child lives a strong and healthy life. There is no law that, or no punishment for someone who doesn't vaccinate their child in Cameroon. Okay,
thank you so much. The next question. I think we have a question from Manuela. What about the perspectives? Are there strategies put in place to ensure continuous supply and availability of the vaccine in our country? What of the cost? Will it always be free or will it be charged in the long run?
Very interesting question. In Cameroon, vaccines for children aged 0 to 5 years is free under the EPI program. So long as it's in the EPI program, it's going to be free. And in the country, we have, I won't talk much about this, but we have a system of co-financing when it comes to vaccination. So we have vaccines that are bought by the government, but also supported by our other partners like Gavi and UNICEF when it comes to the acquisition of these vaccines.
Okay. We have another question. I know Dr. Pamela mentioned that vaccines have a great shelf life. How great is great?
So what I mentioned is that it has a half-life of 3 years.
Okay.
Which means that the vaccine can be kept in the cold chain for up to 3 years without any problem. I hope that is understood.
Okay. This is another question. I think I was talking with a midwife, I don't know, a nurse once, and the nurse was really confused. I think it's a beginner nurse, and she was confused because she was giving out IPT, and she was telling the people she was giving out malaria vaccine. So I would like if you can clarify the public about the difference between IPT and the vaccine, because it's very important. Some parents are actually being some people administer the IPT and they think they're being given the vaccine. And such misinformation can go a long way to damage, because in case where the vaccine actually is now being rolled out in those regions, you have conflicting information where parents begin to tell you, well, I've taken the vaccine, so which other vaccine is this? So I'll really love if you can clarify just briefly the difference between the IPT and the vaccine itself, the malaria vaccine, because I think I've interacted with a couple of people and there seems to be some conflict of misinformation with respect to that.
It's information that's very important to know. IPTI or IPT infants, intermittent preventive treatment, is not different from what is administered to pregnant women. Remember, we'll talk about IPTP that is administered to pregnant women. We have the same in children. And just like Dr. Itoe mentioned, it's the combination of all these interventions that even strengthens the efficacy against malaria. So the IPTI is a tablet, sulfadoxine pyrimethamine, that is taken by the child, and it's administered to children who are administered to children at 10 weeks, 14 weeks, 6 weeks, 9 months, and 15 months. While the VAP or vaccine against malaria is a vaccine which is administered in 4 contacts. So we have at 6 months, at 7 months, at 9 months, and also at 24 months.
Okay.
That's a major difference we should know about these two. IPTR is sulfadoxine pyrimethamine, which is a tablet, a medication, while the malaria vaccine is a vaccine that is administered in 4 doses.
Thank you so much for this session. I cannot even begin to appreciate you more than this, Dr. Itoe and Dr. Pamela. Thank you so much for accepting to give us such valuable information. We normally love to make sure our programs are strictly 1 hour, and this is 5 minutes after 1 hour. So yes, the vaccine is injectable. I'm seeing a question from Manzo. The vaccine is injectable. If you saw the slides, which you also receive as well, you see how the vaccine looks like. So I just want to give a shout out. We have some people in our midst. We have Dr. Ringo. I think he's a malaria expert, USAID, US Embassy Cameroon, and he's a former regional coordinator for malaria in the Northwest region. I don't know if Dr. Ringo is around. Maybe you can just give us 1 or 2 words with respect to the malaria vaccine rollout in Cameroon presently. Is Dr. Ringo still with us? I don't know if Dr. Ringo is still with us. We also have Dr. Sylvester from UNICEF Southwest. Is Dr. Sylvester with us? Maybe you can just unmute yourself and give us 1 or 2 words, take-home messages about the malaria vaccine in Cameroon. Is Dr. Sylvester with us? I'm seeing Dr. Ringo present. Maybe you can unmute yourself and give us 1 or 2 take-home messages with regard to the malaria vaccine. Dr. Sylvester as well. We also have Dr. Vanessa Tabe from WHO. Please, if you're around, maybe you can unmute yourself just to give us 1 or 2 take-home messages with respect to the vaccine. I think it will also go a long way to boost the morals of those that are present here.
Thank you very much, Madam Adanze. I'm happy to be here. Sorry I joined late, had some other commitments. So just to add that we all are working as partners, and we all must be involved in this advocacy to promote the use of the malaria vaccine in order to eradicate malaria from our nation and Africa as a whole. The other countries, yes, have succeeded to eliminate it with the previous means that existed, but we, with the previous means that existed, we have not succeeded to eradicate it. So as research goes on and development continues, we will keep working to get the best means and the best methods to eradicate this malaria in our setting. So let's not relent and let's keep being partners together, working to eradicate malaria from our setting. Thank you.
Thank you so much. I think if the others are not present, I'll call on Dr. Itoe to give us some closing remarks and 1 or 2 take-home messages in the fight against malaria.
Thank you very much. Thanks to all those who joined. What I want to say is we can end malaria in Cameroon. It's feasible. Cape Verde did it with already existing tools. For this to occur, we need multi-sectoral engagement. We need to increase funding. But most importantly, we need dedication. People need to be dedicated to adhere, to take the challenge, to be advocates in their communities, and adhere to all the tools that we have in the fight against malaria, because research has shown that the adherence is not very optimal. And with this community engagement at all levels, and with the community taking the lead, truly we can end malaria. The vaccine is very instrumental to help us in this our quest. Thank you.
Pamela, Dr. Pamela, just 1 or 2 closing words from you to continue the fight against malaria.
Okay, thank you so much. I'm very happy the session was very interactive and it was very interesting, because this is the kind of platform we always look forward to, a platform where we can share the right information and educate the population about the malaria vaccine, but also the importance of vaccines. So I want to say that these vaccines are safe, very safe, and it has been proven in other countries, and even now with its administration in the Southwest region. So it's an additional tool that we should embrace and use jointly with the other tools that are meant to prevent vaccination, such as IPTI, SP for pregnant women, and mosquito nets. So we should remember that it's to protect us, to protect our children, and ensure that we have a future for our children that is sure and that is free from malaria. Thank you.
All right. Thank you so much. Thank you to everyone that attended the webinar. And we are entirely grateful for giving us your time and your questions. And we hope that we're all going to be advocates of malaria, campaign against malaria. We are going to be advocates of sharing positive information, sharing facts and not fears, sharing realities and not rumors. So thank you so much and see you next time. Have a blessed weekend to everyone.
So let me share my email.
Okay, yes, please do. You can share your email and your LinkedIn platform.
I've equally shared.
All right, thank you
shared
so much.
mine.
Thank you so much, Dr.
So,
okay.
So this is my email. LinkedIn, don't know if I can access it now, but
All right. Thank you so much.
so LinkedIn, my name is Besong Pamela.
Okay, so I'll be closing the session right now. Thank you so much.
Thank you. Bye.
Bye, everyone. Thank you. Amazing session. Bye.
Bye.